you.
Yes, madam. I am also first time seeing you.
Oh, yeah.
Glad to meet you, ma'am.
Me too.
Jaymani, good
Yes,
afternoon,
madam.
ma.
Good afternoon, madam.
Good afternoon.
So we'll welcome Dr. Ilakia, Dr. Kirtana. You are finally a postgraduates?
Yes, yes, ma'am.
In Salem, Vinayaka Mission Medical College. Okay, okay.
Ma'am, our case presentation is on anemia complicating pregnancy. Mrs. Baby Shalini, 28 years old, residing at Salem. She's a housewife, studied 8th standard, belonging to socioeconomic class 5. Gravida 3, para 2, light 2, previous to full-term normal vaginal delivery with her LMP 12/6/2021 with her EDD 19/3/2022 with a gestational age of 37 weeks 1 day. She's booked outside and immunized. Patient has been referred from Idampillai PHC with a hemoglobin of 7 gram percentage, with history of 9 months of amenorrhea, able to perceive fetal movements with complaints of easy fatigability for past 1 month, with difficulty in breathing on exertion for past 2 weeks. History of pregnancy.
Can we discuss in between or at the end of the presentation, ma'am? Sasikala ma'am? Jaymani ma'am? Can
Madam,
we
if
discuss?
you want to interrogate immediately, as and when it will be useful to them, madam.
Okay, okay. Go back to the first slide.
Slide.
Go back to the first slide. So, before that, I just want to say something to the postgraduates. So, these postgraduates must be giving exam for the first time. So, they are given just these cases for, just discussion. But all of you should be aware that even though you are presenting this case, for example, anemia complicating pregnancy, you can be asked on questions on any aspect of obstetrics in an obstetric case. Suppose this woman has hypertension associated with anemia, they may not ask questions on anemia, they may go back to go discuss hypertension. They can discuss on labor management, partogram, labor care guide. So please don't go with the impression when you get a case of anemia complicating pregnancy, they will discuss only about anemia. That is first thing I want to impress upon the postgraduates. So anything in the obstetrics, you will be tested, your knowledge will be tested, practical skills will be tested when you get an obstetric case. And second thing, why you chose to discuss this anemia complicating pregnancy? Kirtana? Why do we think that we should discuss this case, anemia complicating pregnancy?
Incidence of anemia complicating pregnancy is higher in India. It's around 80% in India.
Anything else? Ilakia? Any other point you want to add? Why do you want to study about anemia during pregnancy, complicating pregnancy?
Because in India, nutritional deficiency is more common, ma'am. And prevalence is more higher than comparing to the developed countries, ma'am.
Okay, fine. So globally, there is going to be variation, but why specifically we are discussing anemia?
Ma'am, both direct and indirect cause of maternal death.
Yes,
is,
yes, very good.
50% in
So
India.
anemia is the most common medical disorder, though it is underreported, but it is an important cause of maternal morbidity as well as mortality. Almost 40% of maternal deaths have been attributed to anemia. So every one of us should be able to diagnose and treat anemia. More than that, we should prevent anemia. So recently the ICMR has published that anemia complicating pregnancy is 36.5% when compared to non-pregnant women also, which is 29%. So what is the current maternal mortality of India?
17%.
17%.
current maternal mortality rate? Maternal mortality rate, you understand? Maternal deaths per 1 lakh live births in a given period of time. What is the rate? Maternal mortality rate.
It is around 10%, ma'am.
Percentage? No, not percentage. Mortality rate per 1 lakh live births. 2016-18, it was 113. Is it decreasing or increasing?
Decreasing.
Yes, ma? It is decreasing. So currently 2020, we have come down to 99 per 1 lakh women. This is mainly because we are able to prevent anemia. So we have achieved. So what is the expectation by 2030? What is the global expectation or Indian expectation to reduce the maternal mortality to 70 for 1 lakh live births? Okay. So we have to achieve that by 2030. So preventing and managing anemia is very, very important because anemia is associated with 40% of the maternal deaths and 23% of direct maternal deaths. Indirectly, it may be associated with other diseases like hypertension. Okay, so that is why it is very, very important. You should know everything about anemia. Okay, fine. Coming to this patient, do you think she is at risk for anemia?
Yes, ma'am.
No. So what are the factors from this which you have presented in this slide? She is 28 years, very young. So why should she be anemic?
Ma'am, first thing, she's multiparous woman, ma'am.
Okay, very good.
She is belonging to low socioeconomic class, ma'am. And she's a booked case outside, ma'am. So
She is having antenatal care. That is okay. Booked outside or inside is nothing matter. So here her education level is low, socioeconomic status is low, and she is multi. So these are the 3 risk factors which are important in this woman to have had anemia. Why is she referred?
she referred from PHC with a hemoglobin of 7 gram percentage, ma'am.
7 grams. So how do you, is it a mild anemia, moderate or severe anemia? Is it? Which classification you know?
Severe case of severe anemia, ma'am. Severe anemia complicating pregnancy, ma'am.
Okay. And she is how many weeks of pregnancy?
Ma'am, now she is 37 weeks plus 1 day, ma'am.
Okay, almost term, and she is having only 7 grams of hemoglobin. Do you know the various classifications of these cutoff values?
Yes, ma'am.
ICMR classification, ma'am, is classified mild, moderate, severe, and very severe, ma'am.
Very severe. What is very severe?
If it is less than 4 gram per deciliter, it is considered as very severe.
And WHO and CDC?
According to CDC criteria, first trimester and the third trimester, she should have
Okay, fine.
anemia less than 11 gram percentage, ma'am. According to WHO, mild, moderate, severe, less than 7 grams is said to be a severe case of anemia.
So when she is referred to you with 7 grams from a peripheral health center, your teaching institute, what do you do immediately for this woman?
Admit her.
You will give investigations and send her home, or you want to hospitalize her?
We will counsel her and we will admit her.
Investigations.
Yes, we'll counsel her.
Counsel her and we advise her admission, ma'am.
Yeah, you should not send her back because she is term and she is belonging to severe category of anemia. So you should advise hospitalization, right? Why? Why do you advise hospitalization?
Because anytime she may go into labor, ma'am. A severe anemia, she may, precipitate labor can occur, ma'am.
Okay.
So anytime she may go into labor and
any other reason you want to admit her?
She is also
to check multi-gravida, ma'am, and to check for
So you want to correct, isn't it? You want to correct anemia before she will go into labor, and you have very little time, isn't it? So you should not send this woman to home. Okay, giving outpatient investigations. You may counsel her, but she may not come back also. Okay, coming to the complaints. Next slide.
Patient has referred from Nilampillai PSC with hemoglobin 7 grams, history of 9 months of amenorrhea. She can able to pursue fetal movements well with complaints of easy fatigability for past 1 month, with difficulty in breathing on exertion for past 2 weeks.
Okay, so with these symptoms, will you be justified to send her home? Go back, go back. What is she having? Go back, please go back. Oh, yeah. Easy fatigability for 1 month. So this is the commonest symptom of anemia. She has difficulty breathing on exertion and also palpitation. What is that? I am unable to see.
No, ma'am.
Fatigability and breathlessness.
Okay. So is it caused by anemia or is it caused by normal pregnancy? She may say, I'm not able to work, I'm breathing. You don't know her hemoglobin status. Some pregnant woman you are giving, but she says, I'm feeling very weak, doctor, and I have difficulty in breathing.
It may be physiological also, ma'am. That
Hmm.
difficulty in breathing can seen in normal pregnancy also, ma'am.
That is why I'm asking. So how will you differentiate physiological from this pathological?
Associated symptoms, ma'am, whether she's having any history of palpitation, history of orthopnea, PND, and the history of bilateral swelling of legs, ma'am.
Okay. 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 Now she is having symptoms which are pointing out to pathology, some pathology, and also she is referred as anemia. Okay. Next. Next slide.
History of presenting illness. Patient was apparently normal 1 month back. Now she presents with complaints of easy fatigability for past 1 month. Previously, the patient was able to do her household work, but in the past 1 month, she gets tired with minimal amount of work, which relieves on taking rest. She also complains of difficulty in breathing on exertion for past 2 weeks, which was insidious in onset, gradually progressive, mainly on doing household activities, on climbing stairs, which also relieves on taking rest.
Yeah, go ahead. So next.
Next
Yeah,
slide.
please ask ma'am. Jayavani ma'am. Jayavani ma'am. Okay.
No history of palpitation, chest pain, orthopnea, PND, post paroxysmal nocturnal dyspnea, no history of swelling of legs, no history of yellowish discoloration of skin, no history of fever with chills and rictus, no history of burning agitation, no history of repeated blood transfusion in the past, no history of lower abdominal pain, no history of bleeding or leaking per vagina.
What is the why did you ask all these questions?
To rule out cardiac disease complicating pregnancy, I have asked for associated palpitation, chest pain, orthopnea, paroxysmal nocturnal dyspnea, ma'am.
And yellowish discoloration?
To rule out hemolytic anemia in pregnancy,
Okay.
ma'am.
Very good. Okay, go ahead. Next.
Urinary tract infection, I asked for fever with chills and rictus and burning maturation, ma'am.
Fine, fine. Next.
History of present pregnancy, first trimester, this is spontaneous conception after 3.5 years of second childbirth, diagnosed by urine pregnancy test at 40 days of amenorrhea, confirmed by ultrasound at 2 months of amenorrhea, no history of fever with rashes, no history of excessive vomiting, no history of spotting or bleeding per vagina, no history of exposure to radiation or drug intake. She had 1 injection of TD first visit. No history of folic acid consumption not taken regularly. NT scan not done.
Okay. When was her first visit to the hospital?
Around 40 days, ma'am. After confirming urine pregnancy test at home, she went for went to the nearby PHC, ma'am. At the time, she took ultrasound and she confirmed pregnancy, ma'am.
So what are the other tests they have done at the first prenatal visit? Only ultrasound you told.
Blood investigations like hemoglobin, PCV, pack cell volume, along with urine routine, ma'am.
What are the other tests? Every pregnant woman, irrespective of gravity, parity, we do.
Oral glucose tolerance challenge test, ma'am.
No, you should be able to tell everything, no? Hemoglobin, urine, after that.
Yes, ma'am.
Yeah. Screening for infectious diseases.
Urine road
What
culture.
else? How is it done, hemoglobin in your hospital?
Scanning by auto analyzer.
Is it a point of care test, or you give the investigation and send her back and ask her to come after 2 months or 1 month?
Every visit.
Calorimetric test, ma'am.
Hmm.
Every visit.
No, is the report available immediately
Yes, ma'am.
on the same day?
Yes, ma'am.
Oh, okay, that's very good. Okay, fine. Next. How many visits in the first trimester? Only one visit?
Only one visit she went to that nearby PHC, ma'am.
So what was her hemoglobin? Did they check and did they tell what was her hemoglobin?
Patient, she doesn't have any reports, ma'am. She said it was normal. They said it is normal only, like that patient said us, ma'am.
Blood test was done on the same day and she was
And
told
that-
that it
yes,
was
ma'am.
normal. Okay. Okay, fine. Why do you think it was normal in the first trimester and later she became anemic?
Ma'am, she had 2 children at home. She cannot able to take care of herself, like that patient was saying, ma'am. She cannot able to go to a routine antenatal checkup every month. So she did not have adequate supplementation also.
So what was the advice given at the first prenatal visit?
Ma'am,
What was the advice given by the doctor? Have they given any medication for her? Supplements?
Previously, during the first trimester, the hemoglobin was found to be normal only, ma'am. They gave folic acid, but patient did not take it regularly, ma'am, during the first trimester itself, ma'am.
So can you give hematinics, iron, folic acid and calcium in the first trimester?
No, no, ma'am.
Why you should not give? Suppose her hemoglobin is 8 grams. 8 grams, she falls under mild or moderate. She is moderate anemia, isn't it? 8 grams. So why you should not give oral iron in? Because this is a myth. So she's why you should not give? We should not treat moderate anemia in the first trimester.
If she required, now we can start during the conception period itself, ma'am.
That is very fine, but most of our women are not having that. But this woman came only in the first trimester. I'm saying there is a myth even among the doctors, the nurses in the first trimester. You should not take iron and calcium. Why is that? You should not take iron. Why is it contraindicated? Is it contraindicated or you are simply not giving it because of some reason?
In first trimester, she might be having hyperemesis, ma'am.
Might be having, but if she does not have any symptoms of gastritis and she is having, that is what here you have to catch this woman who is having moderate or mild anemia and you have to treat it because this is a myth, this is going on. So they just simply don't treat anemia in the first prenatal visit when you diagnose mild or moderate anemia, thinking that she will have vomiting, which is wrong concept. Okay, there is no contraindication. You have to treat. Diet modification, she cannot take the diet, so you must give these supplements. I mean, therapeutic dose of iron. It is not contraindicated in first trimester. Okay, please go ahead. Next.
Second trimester, quickening felt at 5th month of amenorrhea. Second dose of tetanus diphtheria vaccine taken at 5th month. OG oral glucose challenge test was found to be normal and it is 74 milligrams per deciliter. Anomaly scan taken at 5th month and anomalies ruled out. Prophylactic iron and calcium tablet was not taken regularly and no history of blurring of vision, headache, epigastric pain, fever edema.
So how many visits in the second trimester?
Second trimester only for taking anomaly scan alone, she went for that PHC, ma'am. After that, she did not go to that PHC, ma'am.
No, but what was advised? You can ask the woman what was advised.
It's advised to have regularly iron and calcium, ma'am.
Hmm.
And advised to come around.
Can you
20
give iron and calcium together? How exactly you will advise the woman to take iron and how you will advise her to take calcium?
Iron is
Calcium separately.
taken in empty stomach, ma'am. Because of gastritis, it can be taken after 1 hour after meal, ma'am. But iron and calcium should not be taken at the same time because of the absorption. It inhibits the absorption of iron, ma'am. So
Okay, very good.
giving iron in the morning, afternoon, we can give calcium, ma'am.
Okay, okay, fine. So this needs to be told to the woman. We have hardly any time to explain, but this needs to be clearly stated. So what other food you will advise to increase the absorption of iron?
We can
Dietary advice.
Lemon rice. Lemon
What she
juice.
should take and what she should not take.
iron absorption enhances like vitamin C tablets we can give along with iron, ma'am. Then citric acid content foods we can advise her, ma'am.
Foods rich in iron, Amma?
Green leafy
Fruits which
Or non-vegetarian.
like
Vegetarian.
pomegranate, dates,
Liver.
and can be advised, ma'am. And
meat and meat products can be given, ma'am. Jaggery we can advise, ma'am. Fruits like apricots, apple, pomegranate, guava we can suggest guava, ma'am.
Okay, very good. Okay, fine. Will you be able to, give the meal plan based on the, likes, dislikes of the woman, socio-economic status, whether she will be able to buy meat, liver, and all those things. So you have to specifically, so our diet is specific for each individual. So that much of time we are not having. So that is why there is a necessity of dietitian in every antenatal clinic, which WHO recommends that you should have a dietitian, because doctors are busy with the, especially in government hospitals, we are so busy with the patient crowd. So you must have a separate dietitian in your antenatal clinic, which they take proper history and then they can advise a meal as per the requirements. Okay. Right. This you should be aware that what are the recommendations by WHO. Okay. Next. Next. No.
Third trimester, she can be able to perceive performance well. No history of lower abdominal pain, no history of bleeding or leaking per vagina. Growth scan taken and found to be normal. Iron and calcium tablets was not taken regularly. Complaints of easy fatigability for past 1 month, along with difficulty in breathing on exertion for past 2 weeks. Blood investigations was done at PHC and hemoglobin found to be 7 gram percentage. And they advised admission at PHC for further management, that is blood transfusion, but patient denied. She had only 1 visit during her third trimester, ma'am. During that period only they found her.
So is this antenatal care adequate for this woman? Did she have adequate antenatal care
No, ma'am.
as per your presentation?
He was not monitored for not taking iron tablets.
Now, how do you advise? Suppose the patient has come very early in pregnancy, 40 days of amenorrhea. So in the first prenatal visit, how do you advise regarding further antenatal care visits? So what are the maximum visits and what are the minimum visits?
Minimum.
And how do you stratify the risk?
Ma'am, minimum she should have 5 antenatal visits, ma'am. First trimester she have 1, and second trimester she should have 1 visits, and in third trimester 2 to 3 visits.
Now, is this universal? That is why I asked this question, because this woman in the first prenatal visits, I don't know, you have not put up her clinical and laboratory investigation. You should have put up, if she has the record with her, you should have put up that. So based on the evaluation in the first prenatal visits, you should do risk stratification. You should know the WHO model for low risk women and high risk focused antenatal care for the high risk women, how many visits, and at each visit you have to re-evaluate for factors, because the woman may not have medical disorders, all medical disorders in the first prenatal visit. Okay, so based on the past obstetric history, family history, you should, stratify the risk, whether she is low risk or high risk at each antenatal visit. The risk status changes. So if she is low risk, you say that 4 antenatal visits, as you just told, minimum, okay, before term. If she has like anemia or any other medical disorder, diabetes, you must advise more frequent antenatal visit depending on the condition, hemoglobin level, or blood sugar levels, or hypertension, or any immunological disorders, heart disease, right? So for each woman, the antenatal care visits differ. It is not just 4 visits or 10 visits like that. Okay. So in the first trimester, we lost this woman. Second trimester also, you're just telling all 3 times she had ultrasound, ultrasound, ultrasound. We don't know the clinical findings. So what is the gestational age at which, anemia manifests? We said first trimester she was normal. What gestational age anemia manifests?
Ma'am, it's usually seen common in the mid trimester, ma'am.
Yes, mid trimester, between 14 to 28 weeks. Clinically, it will manifest. So what is your understanding when you diagnose anemia clinically? What is your understanding?
As, physiological changes during pregnancy, that is.
No, what is your understanding? What are you thinking that, she is clinically pale? That means what happened to her iron stores?
Iron stores
What
look
happened to
exhausted
the
by the time
stage
iron-
of anemia? What stage
then
of
iron
anemia?
deficiency
Clinical anemia
manifest.
means there are 3 stages, isn't it? In iron deficiency
These are three
anemia, which is most common, 80% are iron deficiency anemias, okay? 10% megaloblastic. Other causes of anemia are around 5 to 10%. So most common is iron deficiency anemia. So when she is clinically pale, that means which stage? There are 3 stages, isn't it? Stage 1, stage 2, and stage 3.
Stage 3, ma'am.
Stage
Stage
1
3?
is
Stage 1 NMC.
stage 1 is depletion of iron stores, ma'am. And then stage 2 is
That will be deficient in erythropoiesis, ma'am.
Yes, very good. So stage 1, the stores are depleted. Stage 2, erythropoiesis has become defective. Stage 3, what has happened?
That will be
that
iron
will be
deficient.
deficiency
Iron
So
store,
stage
iron
3,
level, serum iron level falls.
the red cell indices are affected. The production of
Red
the
cell,
RBCs
serum
will
iron
become
level falls.
hypochromic and microcytic. So this is very, very late by the time clinically manifest. So she does not have any iron stores. Erythropoiesis is, so the clinical recognition of anemia is a very late thing. That is why you have to depend on laboratory, isn't it? Okay. So when you diagnose anemia clinically, what are the investigation you want to do?
Degree of anemia.
What investigation
Type of
should you
anemia,
do?
cause of anemia.
Depending upon the severity
So
of
what investigations? You diagnosed anemia clinically, clinical diagnosis anemia. So what are
All
the
clinical
battery of
all
investigation you want to do?
கீழே குனிஞ்சு போ.
anemia, we are supposed to do complete blood count, ma'am.
Complete hemogram. Say complete hemogram. What all complete hemogram includes?
it includes hemoglobin, hematocrit, RBC count,
So, total
Red
count.
cell indices. What else? Peripheral smear, which is
Peripheral
most
smear.
important, which will give you the clue for what type of anemia, the etiology. So please tell me on peripheral smear, how do you suspect the etiology?
in iron deficiency anemia, there will be microcytic hypochromic cells, ma'am. Along with it, there will be change in size and shape of the RBCs, ma'am. That is anisopoikilocytosis will be evident in case of iron deficiency anemia, ma'am. In case of megaloblastic anemia, to differentiate from iron deficiency anemia, there will be oval macrocytes will be evident, ma'am, along with hypersegmented neutrophils.
So platelets are also reduced. WBC reduced.
Thrombocytopenia will be there in megaloblastic anemia, ma'am.
Okay, platelets reduced.
There will
Okay.
be
The
augmented
WBC reduced, the RBC count reduced now on peripheral smear. What is your diagnosis?
everything is like pancytopenia, ma'am.
Yes, yes, pancytopenia.
Anemia, ma'am.
Pardon me?
Aplastic anemia,
Yes,
ma'am.
aplastic anemia. So what is the, this is the report, or what next you will do? How do you confirm that it is aplastic anemia?
Bone marrow.
marrow biopsy.
Bone marrow aspiration. So what are the indications for bone marrow aspiration in anemia during pregnancy?
Ma'am, if the patient
One
is
is pancytopenia, you said. There's some other one more indication you must tell. Suppose this woman was given, iron, therapeutic iron during second trimester for 2 weeks or 4 weeks. Then when do you check the hemoglobin? You check the hemoglobin and it remains 7 gram%. That means with a therapeutic trial of iron, when the hemoglobin does not rise, then also you must suspect the bone marrow failure. Okay. And then go ahead and do bone marrow aspiration. Right. Okay. What are the other investigation you do after complete hemogram? What are the, is it necessary to do folic acid, serum folic acid, or serum vitamin B12? If the peripheral smear is diagnosing as macrocytic anemia.
if we can able to see macrocytic anemia, na, we can go for fasting folic acid levels, ma'am, and erythrocyte folate levels, ma'am. If the value of serum fasting,
Is it available everywhere? Is it available
no, ma'am,
in
it is very
government
expensive and it is
hospitals?
not available everywhere, ma'am.
So what will you do in a government hospital?
You can
Is it mandatory to do serum folate levels and serum
ma'am.
vitamin B12 levels, or you can treat her empirically?
we can treat her empirically. We can treat her empirically with vitamin B12 and folic acid. Can
Okay, fine. Okay. Okay, right. Suppose, what are the other tests you've not told? One is complete hemogram. What are the other tests you will order when clinical anemia?
Serum ferritin levels for iron stores we can check, ma'am.
எப்ப கிளம்புறாங்க
இப்ப கிளம்புறாங்க அவங்க அதுதான் சொல்லிக்கிட்டு இருக்காங்க
அதை நீ சொல்லி இந்த குத்துறோம்
Blood indices like MCV, MCH, MCH.
That is on complete hemogram. Okay, complete hemogram over. Okay. Then if there is a pancytopenia, you go for bone marrow aspiration. And if it is macrocytic anemia, you may do depending on the availability of the investigation, but it is not mandatory. You should not insist. You should go ahead and start the treatment for megaloblastic anemia, right? So suppose, what are the other investigations for nutritional anemias?
over the liver function test.
Stool overcyst you will do?
Yes, ma'am, to rule out.
What are like that? What are the other investigation? Liver function test, renal function test,
And urine routine can be done, ma'am, to rule out
urine.
urinary tract infection.
Yes, culture you have to do. Urine
Routine and
culture you
urine
have to do.
culture, ma'am.
Okay, fine. Right. Go ahead. If she is having clinically jaundice, then what test you will do?
We will go for LFT, ma'am, unconjugated bilirubin and
Urobilinesin. So can you diagnose some anemias, these hemoglobinopathies on peripheral smear?
Yes, ma'am.
What are they?
Targets, presence of target cells indicates thalassemia, ma'am, and sicking of
Sicking of
So peripheral smear you must mention, and by that you will decide on further investigation whether it is a congenital cause or aplastic anemia or hemolytic anemia. Okay, so go ahead. Next, there is less time to discuss this. Okay, go ahead.
menstrual
Nothing important in menstrual history, marital history, nothing important. Next, any family history? There is a family history. Okay, past obstetric history. Fine, past obstetric history.
past obstetric history, first pregnancy, it was a spontaneous conception after 2 months of marriage, antepartum period uneventful, no history of anemia or preeclampsia during the first pregnancy. She had regular antenatal visit. She went into
Anything important you mention? Otherwise, no need to read all this. So what
Okay.
is important here in the first pregnancy, past obstetric history, she didn't have anemia during pregnancy and she didn't have postpartum hemorrhage, no history of blood transfusion, and no contraception. So no contraception.
She was not in
What is your comment?
contraceptive usage, ma'am.
So did she continue her hematinics? So the woman is delivering, no anemia, we are discharging her. So what is your advice when you discharge the woman after delivery? What is your advice, Ma?
We'll advise her to continue iron and calcium for another 12 weeks, ma'am. And then we'll
12
advise
weeks or as long as only 12 weeks, as long as she breastfeeds. So you have to do a hemoglobin after delivery. And if she is found to be, many a times we do hemoglobin, clinically fail. So how will you treat that? Postpartum anemia, suppose her hemoglobin is now 7 grams. She delivered during this pregnancy, first pregnancy. She had 7 grams of hemoglobin on the day after her delivery. What do? You discharge with what?
with parenteral iron. We can
Yes. So you simply should not discharge her with oral iron, and you try to correct the iron deficiency. So how will you give parenteral iron?
go with iron sucrose, ma'am.
Iron sucrose, again the woman has to stay for long time. Is there any other preparation which you can give, which is recommended now? Yes, please.
Pericarboxymaltose, ma'am.
Yes. How many milligrams of iron it has?
1000
milligram.
milligram of iron, ma'am, in a single bolus.
Okay.
IV we can give, ma'am. but
Any side effects with that?
anaphylactic
ma'am.
reaction is
No,
rare, ma'am. So we
Hmm.
can go for pericarboxymaltose, ma'am. But it is
Very, very rare. Okay.
Yes,
Okay. If
But
at all
it
any
was-
reaction, there may be dizziness after giving this injection, then you can manage with hydration and supportive therapy. So this woman, we don't know what is her postnatal hemoglobin. What was the advice given, whether she has taken her. So that history you should have taken here in the past obstetric history after delivery. How long she has taken hematinics, what was her hemoglobin level. So what is the recommendation for postnatal care now? The current recommendations, Government of India,
ma'am,
OBG recommendations.
60 milligram of elemental iron with
No,
400.
postnatal visits. How many times you must see the woman now after delivery? Or you should call her only after 6 weeks. What about the postnatal care?
Call her after.
So now the government recommends to correct all this, 3 visits in the postnatal period before 6 weeks, 2, 4, 6. So during this period, along with the contraception, you also have to take care whether she has got anemia. Okay, and correct it. Right, next please. So this history you have to take, how long she has taken hematite. Next, no contraception. Okay, fine.
And contraceptive usage.
Contraception, will it help women not to become anemic?
Yes, ma'am.
Spacing. So it helps
Okay.
her.
Second pregnancy, go ahead, tell the important points in the second pregnancy. She conceived 2 years, then
2 years after first childbirth, antepartum period, intrapartum period, and the postpartum period was uneventful, ma'am. No history of postpartum hemorrhage, no history of blood transfusion in the past.
so she had a low birth weight baby. As
Yes,
I
ma'am.
can see it, that 2.3 kg. What was her first baby?
2.7 kgs, ma'am.
Okay, now she has had low birth weight baby, but we still, you don't know, you couldn't get the history whether she had anemia. You've written no history of anemia. Okay.
Yes.
So anyway, I don't expect you to get that unless she has the discharge slips with her. Again, she breastfed for 2 years.
Yes,
So what
ma'am.
is that breastfeeding doing for the woman? What's happening?
She will be on lactational amenorrhea, ma'am. So ions we can she can get her replenishment of iron stores will be there, ma'am, for 2 years. So
Okay, fine. Next, again, there is no contraception. This is another risk factor. Next, Next, similar things. Next.
Ma'am,
So-
past history, no history of diabetes, hypertension, tuberculosis, malaria, bronchial asthma, thyroid disorders, epilepsy, jaundice, coronary artery disease.
What is this chronic drug intake? What are the drugs that may cause anemia?
Anticonvulsant drugs, ma'am.
Hmm.
Dopamine like methyl-dopa, levodopa, ma'am.
Yes.
Then
And a chronic ingestion of aspirin. Suppose this woman, any woman, we are advising for prophylaxis for hypertension. She is more prone to get, anemia. But you will not diagnose because there is a hemoconcentration in hypertensive disorders. So you think that her hemoglobin is normal. Okay, that is one pitfall. Diet. Where is the dietary history, Amma? Okay.
dietary history, ma'am.
Hmm.
Patient said usually she will be eating the leftover food by her kids, ma'am. So she will the dietary history during morning she will be having 1 cup of tea. Along with that, she will be having her leftover food by her children.
Okay, what do you think? What is deficient in her diet?
Ma'am, both protein deficiency and iron deficiency is
How much? How much protein deficiency? How much calorie deficiency? What kind of diet she is eating? Only carbohydrates.
carbohydrate rich diet only she is eating, ma'am. Protein rich, she is deficient of protein rich diet, ma'am.
Hmm. What are the other history you could have taken? She is vegetarian, non-vegetarian. You said tea. She is
She
taking
consumes
tea.
mixed diet. Yes, ma'am. It is one of the inhibitor of iron absorption, ma'am.
Okay. So can you correct the diet of this woman?
Yes, ma'am. We will be asking her to avoid consumption of tea, ma'am.
How will you correct in a simple way? Suppose she is a non-vegetarian or she is a pure vegetarian. If she is a pure vegetarian, how will you correct? So which type of anemia is common in pure vegetarians? Agaloblastic anemia.
Agaloblastic
So how will
anemia,
you
ma'am.
correct? Diet type of food is very, very important. Okay. So you have to know what type of food to advise a vegetarian and which type of food for non-vegetarian. Non-vegetarian, what is the cheap and best food?
Red meats like liver, kidney.
Those are costly, no? Eggs, you don't want to give her eggs and milk.
Yolk, ma'am.
Drumstick leaves. Okay, ragi. Okay, these are all cheap. So you have to choose out of the foods which she can afford. Okay, right. Next.
Family history, no history suggestive of diabetes, hypertension, tuberculosis, bronchial asthma, thyroid disorders, epilepsy, jaundice, multiple
So
pregnancies.
she's got, I think that she's got a history of sickle cell anemia.
Okay, ma'am.
Hmm. What do you do now? You think this woman is having sickle cell anemia?
We will screen for her, ma'am. We will go for screening tests like HP electrophoresis, ma'am.
Okay, so you diagnosed her sickle cell anemia. How do you manage? What are the problems?
Also look for the partner, whether
Screen
he
for
is
partner,
screened.
ma'am.
How do you manage? How do you prevent? What is the problem with sickle cell anemia?
Mostly thromboembolism.
So you have to give thromboprophylaxis with aspirin and heparin also. Okay, otherwise she will end up with, abortions, stillbirths, and you have to hospitalize her when she gets the episodes of sickle cell crisis, right? So how do you treat aplastic anemia?
We should avoid patient going for dehydration, ma'am, because
Just mainstay of treatment you tell, lack of time I'm asking this. So you have to keep the hematocrit around 20% and you give blood transfusions, that is package cell transfusions. Almost every 2 weeks you have to measure her hemoglobin and counts and then supplement with patch cells, and also sometimes when the platelets comes down you may have to add the steroids or you may have to give platelet transfusion also. Okay, factor transfusion also. So what is pregnancy induced hemolytic anemia? How do you manage that?
We should give proper and adequate hydration, ma'am, to avoid that sickling crisis, ma'am.
No, pregnancy induced hemolytic anemia. Suppose there is a hemolysis.
For hemolysis, we will go for blood transfusion, that is packed cell transfusion we will go for, ma'am.
Any drugs to prevent hemolysis or to stabilize that the hemolysis does not progress faster? You should give here glucocorticoids. Okay, even though it is just a pregnancy induced hemolytic anemia which may disappear after a delivery, during pregnancy you have to maintain the bilirubin levels, you have to prevent further hemolysis, so you go for glucocorticoid therapy. Fine. So
Okay.
you give more blood transfusions, so the bilirubin level is going to increase. Even though the cause is not known, pregnancy itself will act as a immune mediator and cause, this red cell destruction. Okay, these are very rare, but you must know the basics of that. Okay, fine. So how will you treat this woman now? 37 weeks admitted at 7 grams hemoglobin. Now, how will you manage this woman? She is having dyspnea. She is not in failure. What are the findings? Quickly tell what are the findings? Findings, physical findings.
Physical findings.
Pallor 2+. What do you mean by pallor 2+?
Patient is severely anemic, ma'am.
So first you have to tell here pulse rate and pallor. Okay.
Okay, ma'am.
Then next.
Bilateral pitting fetal edema was present, ma'am.
Okay, next, what about JVP? Is she in failure?
JVP is not elevated, ma'am. Pulse rate is around 104 beats per minute, ma'am.
Okay, next.
Systemic examination, ma'am. CVS S1 S2 hurt in all areas, no murmurs, no thrills, respiratory
Okay.
system, bilateral
So
normal,
if she has hepatosplenomegaly, what do you suspect?
hemolytic anemia, ma'am.
Okay, fine. Next.
Obstetric examination, inspection, abdomen longitudinally distended, umbilicus
Just
in
tell the
midline and-
positive findings. Is the gravid uterus corresponding to the gestational age?
Yes, ma'am. Patient is uterus is fundal height corresponds to term gestation. Uterus was not acting.
So
Fundal
fine.
growth
Is
of-
there any IUGR in this case?
No, ma'am.
Okay. Okay.
Liker appears adequate. Abdominal girth 92 centimeters. Symphysis of fundal height 34 centimeters. Estimated fetal weight is about 3.41
So
kg.
she is say that you hospitalize the patient after 2 days, so she is gone into failure. So how do you manage her?
We have to give.
Ma'am, we will be
We have to manage patient with oxygen and we have to give transfusion with the diuretics and digitalization has to be done.
and IV fluid should be restricted, ma'am.
Like 75 ml per hour, it should be the ideal.
First you have to tell what all you will do in a systematic order. She is in failure, so you keep the patient propped up position, oxygen. Then you start furosemide. You have to tell the dose. Then
Ma'am, we will be admitting the patient, ma'am. We will be
then
giving
you
tablets and
start blood transfusion, isn't it?
Yes,
Okay,
ma'am.
you correct the failure and simultaneously you give blood transfusion. So you must know how will you give blood transfusion to a pregnant woman. What are the indications for blood transfusion during pregnancy and during labor?
When she is less than 36 weeks and hemoglobin is like around 5 to 7 with
So at any trimester, if the anemia is very severe, that is less than 4 grams or equivalent to 4 grams, you have to treat her blood transfusion because you have to correct the hypoxia. So nearer term again at 37, 38 weeks, again you don't have time, so you have to correct the anemia very fast. So you have to give blood transfusion. So packed cell transfusion. Suppose the blood is not available, specific group at 37 weeks. What do you give here?
Carboxymaltose can be
Yes, carboxymaltose can be given. Yes. So she has gone into labor. How do you manage the first stage, second stage, and third stage?
First stage, we should be making the patient in proper position, ma'am. Bed rest should be given, ma'am. Oxygen delivery should be adequate, ma'am. Along with that, strict antibiotic prophylaxis should be started to avoid infections, ma'am. And adequate pervaginal examination should be avoided, ma'am. We should minimize PV examinations during the first stage of labor, ma'am. Along with that, IV fluid should be restricted, and we should be ready with cross-matched blood, ma'am.
So the minimum hemoglobin at labor is around 8 gram%. It should be there. Otherwise, again, you need to transfuse the blood very slowly. So over how long? 4 to 6 hours.
4 to 6
you have to
hours,
give each pack. And in second stage, to prevent failure, what should you give?
Ma'am, we should cut
Furosemide. You must give furosemide, isn't it?
And we should avoid her to bear
So
the
how do you define PPH in a woman who is anemic?
PPH. If blood loss more than 250 ml, ma'am, if she is anemic, she can't withstand when blood loss was more than 250 ml.
So otherwise, what is the definition of PPH?
And in normal vaginal delivery, the blood loss is more than 500 ml, and when hematocrit value falls less than for 3%, it is PPH. For cesarean section, if it is more than 1000 ml, and
That's okay. Here for this woman. Suppose the blood loss is less than 500 ml, but she had tachycardia, she had hypotension. Then do you call it PPH or not? She just lost only 200 ml of blood, and
yes,
then her parameters.
Patient can't withstand the minimal amount of blood loss, ma'am.
That is how. Still, in an anemic woman, even if it is less than 500 ml, her pulse BP is deteriorated, then also you have to categorize this under PPH. Okay. So postnatally, how do you correct this?
Go for parental FCM transfusion, ma'am. Ferrous carboxymaltose, ma'am. Or if the hemoglobin is keep on reducing, we can go for packed cell transfusion postnatally, ma'am. 1 unit PRBC can be
Madam, you please add. I think all the time I am taking. Madam?
No problem, madam. You continue, madam. No. I am
Madam,
observing.
please take over. Yeah. So what are some of the initiatives government of India has taken to, prevent anemia? So prevention is the best thing, because, once any disease occurs, treatment is it's not cost effective, and morbidity is very high, isn't it? So can you name some of the preventive aspects?
Programs.
Programs,
National
government of
programs.
India?
Even in school health programs also you have to tell.
What is MA? Foxy in 2007 is aimed giving iron supplements to all adolescent girls, and it aimed at age 12 every girl should have
12 by
grams
12.
of 12 into 12,
12 by 12.
it is 1. Okay, what are the other initiatives? What is NNAP?
Mukh Bharat is a recent program they have.
No, you must know all these programs, Government of India, what are national nutritional programs, you must know. So prevention, even if the woman is having normal hemoglobin, we are giving prophylactic dose of iron, that 100 milligrams. Government of India is giving 100 days tablets which contain 100 milligrams of elemental iron plus 500 micrograms of folic acid, whereas WHO advise 60 milligrams of
60 milligrams
elemental
of
iron.
iron,
And
800
okay, you know all these things minimum when the hemoglobin is normal, but when she is having mild anemia, you have to give therapeutic dose. This you have to remember, and you have to go on changing. If the woman is non-compliant, you have National Institute of Nutrition, Hyderabad, which has introduced this. You can give 3 or 4 doses of iron sucrose on OPD basis because compliance is so poor. And the other thing is deworming, especially low socioeconomic status people. Nobody is doing stool examination and then treating. Prophylactically, you give 1 dose of albendazole, or if it is not available, you give tablet Mabex 100 milligram for 3 days. So deworming is another thing. Okay. So inter-pregnancy interval, you have to correct the anemia. As you said, pre-conceptional care is essential. And in cases of hemoglobinopathies, you have to optimize her health. See that hemoglobin is at least minimum of 10 gram %, and then give them the drugs like in aplastic anemia, cyclosporin can be given, and optimize the health. Then only also advise her conceive or not to conceive. So this woman, what do you advise now after correcting the anemia?
We'll go with permanent sterilization.
Yes, permanent sterilization. Okay. So prevention of anemia is very, very important. Start from the child, and then during pregnancy, postpartum, especially now postpartum, they are concentrating so much on pre-postnatal visits, and correct that. Ma'am, you want to add anything, please? So you have to tell during exam also, you will not be given so much of time to present like this. So the presentation may be 10-15 minutes. You have to train yourself to present most important positive points and most important negative point based on that case.
Okay.
But at any time you will be asked in detail. If the examiner feels that something is missing, then he will ask. And all stages of labor, it is a must. You must know, because there is no time, we are not able to discuss. So prevention of anemia, you need to concentrate. And of course, contraception. Again, depending on the type of anemia, whether you advise oral contraceptives or you advise IUCD, you have to specifically categorize for that woman. Okay, in this woman, what do you feel? The anemia could have been prevented?
Yes, ma'am.
Okay. So can you just in summary tell how to prevent anemia in a pregnant woman?
Ma'am, management of anemia and pregnancy, if the
Prevention.
Prevention is to take advise her to take iron-rich
prophylactic,
and then
she should have prophylactic iron and folic acid supplementation regularly, ma'am. We should give deworming like albendazole or mebendazole during pregnancy, ma'am. Deworming drugs should be taken, ma'am. And fortification of iron-rich foods should be supplemented to the pregnant ladies, ma'am.
Even otherwise, fortification, if the diet is so deficient and she is having some food taboos, yes. So what are the recommended daily allowance supplements that are available commercially? You may have to advise. If you cannot control the diet, you have Mama's Breast and Mother's Horlicks, where they have recommended daily allowance for a pregnant woman. You can advise that also. Okay. And education, women illiteracy education, more health education programs should be there, so that you can change the attitude of the woman in taking what are the myths that these women are having. If they consume these iron tablets which are black, baby will be born black, or baby will put on weight. There are lots of myths and superstitions. That is why we are not able to even though government of India is taking a lot of initiatives because the myths are not wiped off, still we are, encountering high incidence of anemia. Okay. I think time is over.
I think the time
Yes,
is
ma'am.
over, ma'am.
Yes, ma'am.
Yes, anything you have any doubts? Candidates, Ilakia and Kirtana, your slides are very good. You presented in detail, and but try to present crisp and most important positive and negative points.
Thank you.
Thank you.
Thank you, ma'am. Thank you so much, ma'am, Dr. Papadasari, ma'am, and Dr. Jayamani, ma'am. Anemia being an extensive topic, you have discussed very well the important points in the short period, ma'am. Thank you so much. Thank you, Dr. Ilakya and Kirtana, for your presentation.
Thank you, ma'am.